Today, we're talking about muscle ultrasound, but let's think of it differently. Not just as another imaging tool, but really as our modern stethoscope for the entire neuromuscular system. It's a true extension of our clinical senses.
So picture this. You have a patient. Their muscle is clearly wasting away, but your hands-on physical exam feels surprisingly normal. Then, another patient comes in who can't swallow, and the whole initial workup is completely inconclusive. Now, what if the answer wasn't hidden in some complex lab test, but was right there, visible, at the bedside?
To get us started, let's keep two key clinical questions in mind. First, how can a simple, non-invasive scan actually show us more than a needle EMG in certain situations? And second, what specific visual pattern can point us towards a diagnosis like Duchenne muscular dystrophy, sometimes even before major weakness really shows up?
Now, everything we're about to cover is based on insights from some fantastic recent publications in Current Opinion in Neurology from 2024, Medicina from 2023, and the Journal of Neuroimaging from 2026. And of course, the links to the bibliography are in the description below.
Okay, to really use this new stethoscope, we've got to understand what it is we're looking at. So let's make that shift from just feeling the muscle to truly visualizing its inner architecture.
And this is the fundamental concept right here. On the left, you see healthy muscle. We call this the starry night appearance. See how it's mostly dark with these bright little specks of connective tissue? It's beautiful. But on the right, that's diseased muscle. It's much brighter, almost white. And that clear, organized architecture is just gone.
The reason for that difference is something called echogenicity. It's just a measure of how tissue reflects ultrasound waves. Healthy muscle is dark, or hypoechoic, because the waves pass right through. But in disease states, as fat and fibrous tissue start to infiltrate, the muscle reflects more of that sound, making it appear much brighter, or hyperechoic. Honestly, this one principle is the absolute key to interpretation.
Now, the tool we use most often is B mode, or brightness mode. That's what gives us that standard grayscale image we just saw. But there are some exciting new techniques on the horizon. One you should really keep an eye on is shear wave elastography, or SWE. Instead of just looking at brightness, it actually measures tissue stiffness, and it's showing incredible promise for telling apart different dystrophies and myotonias. All right, so let's apply this at the bedside. With this kind of visual data in hand, we can actually start to differentiate between the major categories of neuromuscular disease right then and there.
And this table really breaks it down for us. For myopathies, you're generally going to see a homogeneous, diffuse increase in that brightness, and the muscle bulk is often preserved, especially in the early stages. Now contrast that with neuropathies. Here, the changes are patchy, inhomogeneous. Atrophy is a key feature you can see, along with fasciculations. And let me tell you, you see fasciculations more clearly with ultrasound than with any other tool, period.
We can even grade the severity of these changes using something called the HECMAT scale. It's a simple 4-point system. It goes from a normal, dark muscle on the left all the way to a severely affected muscle on the right that's so bright, so hyperechoic that you can't even see the bone signal underneath it anymore. It's a really powerful way to track how a disease is progressing over time.
It is so important to frame this correctly, though. A 2024 paper in Muscle and Nerve put it perfectly. Ultrasound and EMG are complementary, not interchangeable. One study looked at 800 different muscles and found they often showed completely different results, which just means each one gives us unique information. Ultrasound is brilliant at visualizing structure, while EMG is all about revealing the physiology. They work together.
So let's get into some specific clinical scenarios where this bedside power really is a game changer. This is where seeing truly becomes believing.
Remember our patient who couldn't swallow? Well, for dysphagia, ultrasound of the suprahyoid muscles is incredible. It has a sensitivity of 93.3% for detecting swallowing problems. I mean, that is a massive improvement over our standard clinical assessment alone.
And we can get even more detailed. We can use it to predict chewing and swallowing issues. We can detect that classic tongue pseudo-hypertrophy in Duchenne, where the tongue looks bigger, but it's really just infiltrated with fatty tissue. We can even see the tongue involvement is much more pronounced in late-onset Pompe disease compared to other myopathies. These are subtle but incredibly powerful diagnostic clues.
Now think about the critical care setting. The impact here is just as profound. ICU-acquired weakness is a huge problem, right? With ultrasound, we can track that muscle cross-sectional area every single day and see losses of up to 30% during an admission. This gives us hard, objective data to monitor a patient's status.
And for motor neuron disease, it bears repeating. Muscle ultrasound is the single most sensitive tool we have for detecting fasciculations. Actually seeing those twitches, especially in the tongue, can be an absolutely critical piece of the diagnostic puzzle for conditions like ALS.
And look, getting reliable, repeatable data is actually very straightforward. You just have to follow 4 simple steps. 1. Always use consistent patient positioning. 2. Apply minimal and consistent pressure with the probe. 3. Standardize your machine's gain and depth settings. And 4. Always compare to the other side. That gives you a perfect internal control.
So how do we put this into practice, like tomorrow? Let's boil it all down to your most actionable takeaways.
Okay,
Here are 3 key clinical actions. First, extend your exam. Use the ultrasound to see what you can't feel, that muscle architecture, early atrophy, those subtle fasciculations. Second, differentiate disease. Just remember the pattern, that uniform brightness for myopathies versus the patchy changes in atrophy you see in neuropathies. And third, guide your interventions. Use it to assess swallowing, monitor the diaphragm, and even guide your needle for an EMG or biopsy. You can boost your accuracy up to 96%.
And if you need a really simple way to remember this, and maybe to talk about it with your colleagues, just think: scan, see, solve.
So the next time you have a patient with muscle weakness and you're facing that diagnostic puzzle, don't just palpate. It's time to visualize.